Hey guys, welcome back to my channel. Today we'll do a fatafat Apla syndrome last minute revision. Okay, so first Apla syndrome is a acquired thrombophilia, right? It's an acquired thrombophilia. Okay, here the history will be recurrent pregnancy loss, hypertension, fetal death, or FGR. Okay, there are antibodies which can be IgG, IgM, IgA. Types will be different, but the main basic types are IgG, IgM, IgA. So basically, every cell membrane have some proteins known as some molecules known as phospholipids. Okay, so these antibodies are against these phospholipids. So once these phospholipids are attacked by these antibodies, the cell bursts and releases the prostaglandins. Okay. Second thing, what happens is in a blood vessel, there are procoagulants that there are procoagulants and there are anticoagulants, right? So the procoagulants will be increasing. So if there is procoagulants, what happens? There will be thrombosis. Okay, so procoagulants will be increases. Not only that, the complements increases. Acceleration of the complements are same. Even syncytial trophoblasts get affected. Okay, there is one condition as CAPS. What is that? CAPS. CAPS is also known as Asherson syndrome. It is a very rare one. But once it is occurred, there is a rapidly forming thrombosis, and more than three organs are being involved within 1 week. Okay, most common involved is CNS, that is brain, and 50% mortality is seen. Arteriovenous thrombosis same. Rarely we can see the psychiatric symptoms. So treatment for this is IVIG. What is that? IVIG. Now coming back to Apla syndrome antibodies, specific antibodies, there are three antibodies we all know. Okay. So first I'll tell about I already told there are phospholipids. So these phospholipids are lipids, right? So these lipids will be bounded by some proteins. So if antibodies are formed against the proteins now, that is known as phospholipid binding protein antibodies. Okay, that is one type is beta 2 glycoprotein. This is the worst antibody ever in Apla syndrome. If your patient came with you with beta 2 glycoprotein positive, that means very worst prognosis. Okay, so what happens is generally beta 2 glycoprotein, what does that do? It inhibits prothrombinase. It inhibits prothrombinase. So what happens? Platelet aggregation will not occur. Okay. So platelet aggregation will not occur. So if there is antibody against this beta 2 glycoprotein, if antibodies against this beta 2 glycoprotein, so platelet aggregate wherever they want, they form thrombosis. So it results in thrombosis and Apla antibodies. Okay. Apla syndrome occurs. Okay. So sometimes they will confuse you. Beta 2 glycoprotein, also known as apolipoprotein H. Okay. Now coming to second antibody, that is LAC, that is lupus anticoagulant. It is not anticoagulant, it's a misnomer because in vitro it increases PT, APT, that's what it is as anticoagulant. But in vivo, it is a procoagulant. It causes thrombosis. Okay. Third antibody is ACA, that is anti-cardiolipin antibodies. These antibodies are against platelets, against the mitochondrial membrane antibodies. Okay. Some other antibodies are there which are against protein C, protein S, and the next 5. Okay. Now coming to clinical features of Apla syndrome. What obviously there are thrombosis. There is venous thrombosis. There is livido reticulari. Sorry. So in arteries also there is thrombosis. So wherever the arteries are supplying, like brain, it causes transition attack. In MI, in the heart, it causes MI. Okay, that way. There is autoimmune hemolytic anemia, and the thrombocytes, the platelets also decreases. Okay. In kidneys, there is a glomerular thrombosis. In brain also it can affect and results in headache, migraine. In joints, it causes arthritis. Normally, pregnancies cause second pregnancy loss, hypertension, FGR, and fetal death. Diagnosis is like criteria known as Sydney's criteria. Sydney's criteria is in lab you should have one, and in clinical diagnosis you should have one. Okay. So lab is three antibodies, that is lupus anticoagulant diluted one. Viper is used, and in AC antibodies should be more than 40 units. Anti beta 2 glycoprotein, which is reversed now. This also in this one should be present. And in clinical criteria, there are four things. One is spontaneous abortions, like small fetuses, like less than 10 weeks, get aborted. If there are three abortions, okay, and if 12 weeks or 15 weeks, like more than 10 weeks, so there is one abortion and venous thrombosis is there. And along with that, preeclampsia, uteroplacental insufficiency with less than 34 weeks when there is preterm delivery. And this is also one of the clinical criteria. So these are Sydney's criteria. So lab and clinical. Okay. So what you'll do, what is the treatment? If Apla plus recurrent pregnancy loss is there, then you'll give heparin. Heparin also is given after delivery, 6 weeks postpartum also will give. Okay. In these three antibodies, if one antibody is present, then 83% abortions occur. If two antibodies are present, then there is 93% abortions occur. So that's why better treat them than go for pregnancy. What is the prophylaxis you give? Enoxaparin, that is low molecular heparin, is given 40 milligrams subcutaneously OD, or dalteparin 5000 OD, tinzaparin 4500 OD. Okay, so for 40, 5000 you give, and then you decreasing a little. Okay, it is 4500. Tinzaparin generally 1 milligram per kg body weight is given. Sorry, therapeutic you'll give 1 milligram per kg body weight. Understood? So prophylactic you'll give 40 milligram, whereas therapeutic you give 1 milligram per kg body weight. That is enoxaparin, and this is given BD. For prophylactic, you give only one dose. See, we're just giving prophylactic. Now we have already a disease, so treatment you'll give double dose BD. Okay, the aldaparin 200 international units OD will give. Okay, factor 10A level should be tested. We all know. And enoxaparin, whenever we'll give in the ward, we'll test factor 10A levels. Factor 10A levels are tested 4 hours after the last injection, and the normal range is 0.6 to 1. Okay, next is unfractionated heparin. Unfractionated heparin is given prophylactically 5,000 in first trimester, 7,000 in the second trimester, 10,000 in third trimester. In unfractionated heparin, you will see the APTT levels. They should be 1.5 to 2.5 times the normal, and you will check after 6 hours. Here you will check after 4 hours. Here you will check after 6 hours. Okay. Heparin plus aspirin in the postpartum also will give. There is any history of VT or history of recurrent pregnancy loss. There is loss. There is VT also. You might have went into ICU. So recurrent pregnancy loss. This is also there is a big loss. So you start heparin and aspirin. Okay. If there is SLE, you will do a hydrochloroquine, corticosteroids. IVIG is used for thrombocytopenia. IVIG is given 2 gram per kg body weight. There's a study going on, that is pregnant study. It already showed the result. If three triple antibodies are present, the live birth is only 30%. If three antibodies are positive in a female, the live birth rate is 30% only. If anti-beta 2 glycoprotein is there now, then stillbirth is 30%. Okay, this 30% chance that baby will grow till term and will die. Okay, so this is the worst antibody ever. Okay, that's about Apla. If you write these points elaborately and if you describe about thrombosis and even the censorship of oblastic, if you discuss about that trophoblastic invasion, then it will be, you'll get easily 7 to 8 marks for this question. Okay? Thank you.